from Miami, Florida. We're broadcasting here on our third week of Neurosurgical TV. Today we have the honor of having Petr Galkin. He's a neurosurgeon from Moscow, Russia. He's going to give a presentation on intracranial bleeding, and we have a distinguished panel from Japan, Brazil, Chile, New Jersey, and Ecuador via Spain, or Spain via Ecuador. And we'll just go around the panel right now and introduce ourselves, and we'll go back to Peter. Okay, Simon, could you please start?
Hello, everyone. Thank you very much for allowing me to be here. My name is Simon Downs. I'm a developmental psychologist working out of Tokyo, Japan. I also work with a bone-conducted hearing aid, and I'm also a medical student.
Welcome, Simon. Julio?
Hi, how are you? My name is Julio. I'm from Neurosurgery blog. Today I'm in the airport, so I cannot talk a lot. Just to listen the presentation. Thank you for invitation.
Welcome, Julio. Okay, Diego.
Thank you, John. Yeah, my name is Diego Menchaca. I am the co-founder of TeamScope, a health app. Currently in Santiago, Chile, we've been supported by a innovation competition called Startup Chile. Thank you, John.
Okay, welcome, Diego. David?
Hi, this is Dave Hunt. I'm a neurosurgeon, vascular neurosurgeon, living in Hoboken, New Jersey. I'm semi-retired and happy to be here. Looking forward to the presentation.
Welcome, David. Okay, Carlos. You need to unmute, Carlos. I make that mistake all the time. Carlos, you want to introduce yourself? Okay, go ahead.
Yeah. Hello, I am Carlos from Neurosurgeon from Spain. I'm working here in Ecuador, and thank you very much for this invitation.
Bienvenidos, Carlos, and we have a late arrival, Hee-Young Kim. Hello, Hee-Young. Can you introduce yourself, please, and tell what you do?
Hello, I'm Hee-Young. I'm in Seoul, Korea.
And what do you do, Hee-Young?
I'm ENT doctor in Korea.
Okay, ENT surgeon from Korea, and he loves hangouts. So
yes,
that's good.
I work in my private clinic.
Okay, okay, very good. Okay, we'll introduce Petr Galkin. He's a neurosurgeon from Moscow, and Peter's going to do his presentation. So welcome, Peter.
Hello, John. Hello, everybody. I am Petr Galkin. I'm a neurosurgeon, and I work in position as a research officer in Research Center of Neurology. And my sphere of my scientific interest is vascular pathology of brain, and it's also the vascular pathology of the neck. I do surgeries for pathology, not only brain pathology, but also for the vascular pathology of the brachiocephalic arteries. So can I start?
Yes, please, Peter.
Okay, thanks.
And I'll let you know how it's going.
I want to present a case of intracerebral hemorrhage open surgery, which we made this surgery almost 1 month ago, and the problem is actual because derived from statistics. Stroke is highly incident in the eastern part of our planet, especially in Russia. Here we see incidence is about 199 per 1,000 population, and it is a second leading cause of death among all deaths in Russia. Annually, we have in Russia about 450,000 deaths caused by stroke, and hemorrhagic strokes are consist about 10 to 15%, and half of them are attributed to chronic arterial hypertension. the case is that the 30-day mortality for deep hemorrhages with volume between 30 and 60 cubic centimeters is about 64%. So it's 2 persons from 3 usually succumb. And of 71 persons who are surviving with such hematoma has independency at 30 days. Only 1 person from 71 have independency. And this derived from this publication that was published in 1993. The tactics nowadays tactics for intracerebral hemorrhage is derived from these publications that first was made in 1961 when there were 180 cases analyzed, and there was no the results of conservative and surgical treatments were almost equal. The second trial was Stitch. It's a modern trial, and they were randomized about 1,000, more than 1,000 patients, and also the results were similar for conservative and for surgical treatments. So nowadays, the tactics looks so that if neurosurgeons have experience and they decide they think and they have experience of removing such hematomas, and they think that they could help the patient, they do surgeries, like in our center. I want to present this case. It was a 52-year-old female patient, and she was found by her relatives at home with a stuporous, with confused conscious, and she, with plagia in right hand and leg, and she didn't speak. She had aphasia, and there was also a very high blood pressure. When
you remember her pulse?
No, she didn't remember it. And on admission, she was drowsy. She had signs of irritation of midbrain, as a divergent strabismus. She was aphatic. She had right hemiplegia, and she scored on NIHSS 22 and on the Glasgow Coma Scale 10 points. She had arterial hypertension. She's obese, and also because she was vomiting. She had vomit. She has vomit. She had aspiration pneumonia. We perform MRI at admission, and we see herniation of uncus, and that was explain her eye movement problems, and also we saw midline shift, and this is our clots here, and our radiologist evaluated, calculate, and said that the volume of clots is about 40 cubic centimeters. Also, we made MRI with diffusion rate images where we saw the blood. Also, there was blood in the fourth ventricle, in the occipital horns. There was level in occipital horns. Also, in the third ventricle, there was blood, and but there was no obstructive hydrocephalus. So we discuss what surgery type we should do, and we discuss between endoscopic removement or between open surgery. The herniation of uncal herniation with irritation of midbrain and fast decreasing of her conscious. She was deteriorated rapidly. Suggested us to perform open surgery. We decided to make decompressive craniotomy with a microsurgical removal of clots with the use of microscope, and then to make a duroplasty without skull closure. After we performed surgery, this CT scans was made immediately after wound closure. The clots were removed almost totally. There was a small level of blood. I think that it is a blood with which was mixed with liquor, and we did not open frontal horn. So you see here the blood in the third ventricle, and also it's a blood. And there is no obstructive hydrocephalus. Actually, we think that it was a potaminal or caudate hemorrhage, because it was on first. I just want to show you. First, we suppose that it is a mixed hemorrhage with a destruction of internal capsule, but on the postoperative scans we see that internal capsule was intact. So we pray God that the patient could normalize, become healthy. Postoperative course was not so smooth. She was 2 days on sedation, we awake her on the second postoperative day. On third day, we observed recover of movements and her right extremities. She was extubated on 7th postoperative day and verticalized on 10th postoperative day and discharged from ICU on the 13th postoperative day. Here I want to show you CT scans on 5th postoperative day. Here we see here's the little amounts of blood also still in her left hemisphere, and here we see that her Cylon fissure becomes differentiates, and on the 12th postoperative day the pictures becomes better, and here's almost no blood on the scans, and but edema of left hemisphere still persists. I made the pictures of her on, with her permission on 25 postoperative day. Here is a scar, and here is the size of skull resection. Here's the size. We made also temporal decompression, and here I want to show you the video of patient. She gave me permission, and just a moment.
The video, huh?
Yeah.
Okay. Let's see if it works.
Just a moment. It's loading.
Okay, there you go.
I asked her name. She speaks, and she has a slight aphasia, mainly motor aphasia.
Okay.
And a little ataxia in the right hand and right leg. You will see it now when she will walk.
Okay.
This is day 25.
It's day 25, Peter? Hello, Peter?
Yes.
Is that day 25?
Yes, it's a 25 day.
Okay.
So I'm very grateful to all staff of our center who participated in the treatment of this patient, and especially for radiologist Sofia Morozova. She did the initial scans, MRI scans of this patient. Also for neurosurgeon Levan Lepsurizi, he assisted me in this surgery. Also for anesthesiologist Roman Polishchuk, he intubated and passed this, helped me to make the surgery as for this patient. Also our surgical nurses, Nastya and Katya, and also ICU neurologist Polina Prokazova, and now the last neurologist who made rehabilitation. Who made rehabilitative treatment for her, Alexei Nikonov. So I want to say spasiba. It's in Russian like thank you, and in Russian it means good God will save you.
Oh, well, great.
Thank you very much.
Peter, that was great. So now we'll have a discussion, and obviously we'll defer to the neurosurgeons on the panel. And why don't you, David, lead the discussion? Because obviously you know a lot more than me about neurosurgery. So could you please lead the discussion amongst the neurosurgeons?
Sure. A few things. First, you're to be congratulated on the excellent results on that. I'm pleased.
Thank you.
It would be useful in a presentation to know the pulse, although clearly with a herniation syndrome, I would expect that to have been down along things. I wonder if she has had, I guess my third comment would be why the ventriculostomy at day 10 and why not a ventriculostomy prior to that. And finally, has there been any thought to angiography post-operatively? This is probably from the perforating vessels, obviously, into the lateral capsule, but it could have been, it could still be an apical carotid bifurcation aneurysm as a for instance, or an arteriovenous malformation. Has there been any thought to angiography?
Yes, I wait for such question, and actually we plan to perform cranioplasty for her maybe in next month, and I will perform CT angiography to check for aneurysm. Maybe I also think that it could be aneurysm of MCA bifurcation, from MCA bifurcation.
Yeah. Tell me about the ventriculostomy, the indications for it, and do you routinely or do you often do early ventriculostomy?
Actually, the ventricle, as you saw, ventricles were too narrow, and there was no ventriculomegaly, and we performed for her. We performed CT scans almost each day, and after second day we observed her in ICU, and we observed for her neurologic condition. So if she would deteriorate, we would perform urgent CT, and if there would be hydrocephalus, we should almost should place ventriculostoma.
Right. Now, a ventriculostomy for you is a ventricular drain or is a shunt? I'm not clear if there is a language.
No, it's a ventricular drain.
Okay, and that was left in for how long? or just an acute drainage?
I think that's usually we place it maybe for not long than 5 or maximally 7 days.
Okay, so she had the ventriculostomy. It was placed at day 10 post-operatively. She had the ventriculostomy and was discharged from the ICU on day 13. So she had a ventriculostomy on the floor. Is that correct? I'm just trying to understand the practice there, trying to understand the sequence.
I didn't. Sorry, David. I didn't understand the last question.
That's okay. That's okay.
She had a ventriculostomy at day 10. Yes.
No, we didn't make. We didn't make a ventriculostomy.
I'm sorry, I thought that I saw that it had been done at day 10.
No, we didn't.
Ah, I misunderstood then.
Okay.
I apologize.
Okay.
Carlos
or
yes.
Or Julio, you have a comment?
Yes. First, congratulations. Very interesting because it's a difficult area. You know, hemorrhagic stroke. There is few papers. You know, there is few evidence how to manage this disease. We have 3 important trials. Clear 3 was published. Clear 2. They work with ventricular hemorrhage, and there is other trial, the name is MISTI. They try to manage as well, you say, you know. The MISTI was published in 2013, if my memory is fine. And the other one you tell, STIC, it's the other important trial. But sometimes I understand you, because in Brazil, sometimes in public health, you have some problems to try to manage hemorrhagic stroke. As in United States, sometimes it's possible, you know, because sometimes you don't have neuronavigation, and the craniectomy, it's an option, in my opinion. There is few papers about this, but sometimes when you don't have neuronavigation, it's hard sometimes to, in public health, you have an ICP. Do you understand what I mean? Like intracranial pressure. And actually, I completely agree with Dr. David Hunt. You know, for me it's very important ICP, because you can sometimes you can wait more. Do you understand? You can put the ICP and follow the patient. It's ICP high. You can do this kind of aggressive operation. But in my opinion, your case, you know, it's the outcome was perfect, and congratulations. In this area, it's very hard how to manage it. Congratulations.
Thank you, Julio.
Just a brief comment as well. The papers cited, the McKissick and the Stitch trial, both from the 60s, were prior to days of either CT or certainly MRI. And I think that practice, as demonstrated by what you did so successfully, has dramatically changed since then. And so I would expect results to be better. I wouldn't necessarily expect them to be as good as they were in this case, because that's really an excellent result in terms of following commands, and even with some aphasia, I would expect that to solve partly. I'm sorry. Go ahead from Ecuador, Carla.
Okay. Hello. Congratulations for its very nice exposition of this theme. I agree with David, but with Julio is because sometimes in many cases these kinds of bleeding are hypertensive in origin. It's very true. You must there is no very clear protocol management. Also, if you are you must do or not an CT angio, you must to see where is the bleeding cause. But if you are in the emergency department, when to do something for some patient, when you see some kinds of herniation signs, you must to decide what to do. Or you will be stay waiting to do one CT angio. If it will be possible to do a very good pictures for them. And for other one, I think when the people doing an craniectomy and a duroplasty, I think I have an experience from here. For example, when to drainage this kind of bleeding, after you didn't not need to do an craniectomy, because if you keep it out the bleeding or the hematoma, they will be a lot of site for these kinds. It's very important to do an ICP monitoring, because you must see the pressure if you need or not treatment. I think it's not at this time you is do it to study stage 1, stage 2, stage 3. But it is not clearly point how to manage these kinds of bleeding. I think for the CTM, I don't know if it's really helpful for us or not. Thanks.
Carlos, yes, thanks. I just want to show you the CT scans on fifth day, and you could see that there was the very huge edema of her left hemisphere, and if we would place bone back to her skull, or if we would not make a wide decompression, I think, and I'm sure that she will die, and there will be no result from such surgery, because we already passed through this through such cases when we made small craniotomies, and when we close it with the bones, and the patients becomes so they didn't reconvalescent, and I just will show you again this picture. So, and I think that it is important in such cases to perform wide craniotomy, and also duroplasty. Just a moment.
While we await that, I would emphasize the importance of a large craniotomy if it's going to be done. The craniotomy and removal of the bone flap. I was a trainee under Dr. Ransohoff, who with Valo Benjamin did the first publication on that, and argued that it could be successful, and then actually retracted that later. Because on review we had problems, but more recently there's been tremendous success, I think, with large craniectomies, and I think that that's an important change in and addition to neurosurgery.
So you see here's a huge vasogenic edema. This is all edema, yeah. And also here is edema, and also here is edema. So if we would close this bone, and we would not cut, and we would not we would not make a dura layer freely, I think that there will be no success in treatment of this patient. You see?
What is your medical treatment for edema post-operatively in such a case?
Actually, it's a better question for ICU specialists, ICU doctors, but sometimes they they make manitol intravenously. Also, sometimes they make hyperventilation, and also we don't use hormones. We don't use dexamethasone, and I think that it was a right tactics that she was sedated for 2 days, and so she could sleep, and her brain could recover. So, and also I think that the right tactic that she was ventilated for 7 days, and also that if we would, so her brain was oxygenated enough, you see. So this, John, we can't hear you, John.
All right. It is a question from the non-surgical section, and actually it's a question about standard of care between the United States and Russia. David, would this be the standard of care for a neurosurgical case in this country? I mean, you can't argue with the outcome, of course, but is this the kind of way that a neurosurgeon would approach a case in the United States as far as the standard of care, or is it different?
I think that this is pretty much standard of care now. I think a decade ago, I might well have said that, particularly with a hemorrhage in the dominant hemisphere, that it was virtually hopeless. And I think that this demonstrates that times have changed and advances have been made. And again, I congratulate I congratulate Peter on the fine results on this. I think that the standard of care varies significantly between institutions still, and the Moscow Research Center is a fine institution that I know well. I think that these capabilities might not be accessible everywhere, either in Russia or in the United States, in smaller hospitals. Access to acute care of the kind necessary to take care of someone when they come in so sick might not be available. And I think that minutes really do count with a hemorrhage this large in the dominant hemisphere. So again, I think that moving fast is good. The one thing that I might do differently, which is interesting, and I'd be interested in Peter's comment on this, is we were in the habit of at University Hospital in Newark of doing CT angiography very quickly. CT angiography, or acute CT angiography with CT, had a couple of advantages. It was faster than MRI. It was easier to get the ventilator into the machine room and to get the test organized. And a CT angiography preoperatively would have a few advantages. One, it would give you an idea of blood flow because you'd have circulation time graphs that you could print out. And two, it could tell you preoperatively whether you might be dealing with an aneurysm or vascular malformation or other non-ischemic to hemorrhagic stroke etiology on that. And so we actually used lower technology, I think, to get results that gave us more information. I think I'd be interested in Peter's comment on that, and also Carlos, you're there. I'd be interested in those comments.
Thank you.
What is your experience, Carlos?
Sorry. I think, for example, when we sit down, we can do everything in every time, because. But I think, for example, if you're doing CT angiography with a very high bleeding, this will be impossible to see very well what kind of bleeding are. From which artery is coming the bleeding. It's depending on the technical working through these kinds of exam. I think it's if you look at, for example, when where is the localization of the bleeding, you will be thinking something. Well, for example, in the last week I was seeing one. Young people who had an arteriovenous malformation. he has the bleeding in a very superficially things, and we do it on a CT angio in very quickly, and we can see very well the feeding artery. Well, when we are in the OR, we see before the surgery we see with CT angio just one bleeding artery, but when we are in the OR during the operation, we are finding two more feeding artery. It's kind of bleeding. The CT angio can help for us in some kind of doing a diagnosis, but it's not very exact. I think if the bleeding is very extensive, very hard, the CT angio is not a very good. I think so.
Yeah, I think it's imperfect, but it can sometimes help. We've actually seen puddling of contrast outside of the area of in the immediately adjacent to the region of bleeding in large hematomas on occasion, and it at least can give you a little extra data about where to look for trouble. I agree that in a vascular malformation, distant vessels can be hidden by the pressure of the hematoma, and that is a risk.
Okay.
Dr. Kim, any comments?
No. I think for it is for the CT angio, we have a lot of things to speak about it, if they help or not. But it is very important who doing the CT angio.
Absolutely.
Who is the technician? Because after you give the contrast for the patient, after you do the image, after you must do a reconstruction of these kinds of image. If you have a very good technician, maybe you will have a very good exam. But if the technician is not an expert people, it will be on a very pure image. This kind of exam will not help for you in your treatment when you must take some kind of decision about the patient. I think so. It's very important the quality of the exam, I think.
Yeah. Certainly, the timing of the injection and the initiation of the studies is important. It's one reason that I have always tried to encourage routine CTAs, just so the technicians can become more familiar with the timing, because that acquisition is critically important, and also a reason that I have strongly encouraged neurosurgeons to learn how to do the reformations of the pictures themselves. I think it's easy enough for anyone as familiar with computers as everyone in this panel is to learn. It's a little bit of a learning curve, but can be fun, and you get so much more information by doing it yourself that's one of the things that I feel strongly about.
Yeah, it's a good idea.
Hello?
Yeah.
No, I completely agree. I just like to thanks everyone, because I have to go. I am in the airplane now. Okay. It was very, very good, really, because it's real. That's our question. Do you know what kind of exam, what you can do? It's real world. I love this conversation today. Thank you very much. See you soon.
Thank you for joining us. Back on Dios. Safe flight.
Have a good flight.
See you again.
That's wonderful. Yeah, the software on all machines right now, well, or at least on Siemens and GE, the only ones I'm really familiar with, are both similar enough. They have different strengths, but they're both similar enough that one can very quickly learn to reformulate the images yourself. And for those panelists here, if you haven't used it, freely available for Macintosh and now I believe for PCs as well, but is a program called Osirix, which is a DICOM viewer that you can put on your own machine and reconstruct images, reconstruct 3D images. And I've found that very helpful in my practice to look at pictures at home, reconstruct them myself, segment them myself from home on occasion. So I would recommend Osirix to anyone with a platform that is supported by it.
Okay.
Okay.
I think this forum is very important to speak with other people, with other neurosurgeons who are doing the same pathologies with different methods, with different approach, different things. For example, I was working in Hungary and in Spain, and now I'm working in Ecuador. But in all these three countries, we didn't have a very good protocol of behavior to do it something. It depends for example, for the radiologic service. When some patient is arrived from the emergency room, you are asking for CT. If the people of the radiology see and a bleeding, intraparenchymal bleeding, something like this, they didn't think about that they must do some for the CT angio. After when you see the study and you call for them, I say, why you didn't do it this exam? I say, no, this is enough for you. It is in the public service. It's very difficult to do these kinds of things. You must ask it every time. It's very hard for us, but we treat to do everything like this. I for example, before to bring the patients for the OR, please doing every kind of the exam. You must be sure. You must be very sure what you will do, what will be you see in the OR. I think it is a very, very important thing for the help to the patient, I think.
Well, you know, one thing that surprised me from what David said this afternoon about imaging is that the neurosurgeon has to get actively involved, it seems, in the imaging process.
I think that's very important. Does everyone on this panel know the program Osirix? Or do you not know?
No, I don't know.
It is a free program. What I am going to do is I am going to load it up here in just a moment.
Oh, great.
And break every law that HIPAA ever wrote, because you'll see a few names on it. Disregard that.
Okay.
Let's see. It's loading as we speak. It should be loading as we speak, yes. And once it loads, I will show you. This is a free program, and now let me go to.
It's an imaging program?
Yeah, it's a DICOM viewer. Just a sec. I'm going to screen share here.
Okay.
So let's see. Can you all see it yet? Not yet.
Not yet.
Okay. Just a moment. Here it comes.
There you go. Okay, we see it.
Okay, so this is Osirix. And what Osirix is it's a viewer. If you look up at the top, you can do 2D or 3D views. on Osirix, and this is something that just runs on my machine. Let's see, it may not work well on the video. I think that it is not happy working with Hangouts particularly. Okay. But basically, you can reconstruct. It's almost a screenshot it's giving here. But basically, you can reconstruct 3D imaging. This comes out of CERN in Switzerland. It's OSIRIX. It is free on Macintosh. There are faster medical versions, but the free version is what I use. It's very quick to learn, and images can be sent to you. People can download the files to your home, and that's what I did for the last 5 years of my practice. I would get a call in the middle of the night, and my residents would say, "I've got a problem here. I think we should do X." Sometimes I would say, "Good, go ahead, get started, I'll be in." Sometimes I would say, "I'm not really sure, let me look at the films." And I would have the films within minutes on my machine to look at them directly. I regret that I don't seem to be able to adequately show you all of what it will do right now, because there's some peculiar interaction with Hangouts that I don't understand.
Oh, well, we can work on that in our off time. Okay.
But go out and look for it. It's a DICOM viewer. It's been around from CERN for years. It's really magnificent, and it's easy to learn. Okay. If you can't do it easily yourself, take your laptop into your radiologist and say, "How do I make this thing work?" And they'll be able to show you. They'll be able to show you very quickly. It's really very good.
Well, if I remember correctly, David, radiologists were the first one to really start to use computers around the hospital.
Absolutely, absolutely. I was actually involved in putting in radiology information systems and hospital information systems in Newark years ago. So
yeah, I remember when they first started that.
Yeah, so I have been curious about all that for a long time, and I also had the benefit of having a wonderful neuroradiologist that I worked with for years. And so for Carlos, one of the things that we did was we probably ordered more CT angiograms than we absolutely needed early on, and we did that partly in order to train up the technician to be able to perform the scans, because once the protocols are well established, once the technicians know what they're doing, it's actually not too hard to do a CTA. But unless you do the right sequence with the right delay on imaging, you end up with little or no information. So just training them up, I think, is an important part of our role as neurosurgeons.
Okay. Okay. Well, gentlemen, Peter, do you have any words before wrapping up?
Yes, I want to say thanks a lot to everybody who had joined today program, today's show, especially for David for his valuable comments, also for Carlos, because it's very interesting to talk with professionals like you, because we talk on one language. Also for Julio, because as I understand, he's a ideologist of this TV. Yes, John?
Yes. Well, it's an honor for all of us to sit in a room with 3 or 4 neurosurgeons.
Yes.
And unfortunately, we couldn't add much to the discussion. But it was certainly interesting, and I'm sure I'm speaking for He Young and Simon that it's an honor for us to be in the same room with you guys. So we're just going to wrap it up, and I'll just say goodbye to the world, and then we'll just sit around and chat. Goodbye, world.